and pharmacodynamic aspects. Today, we'll discuss pharmacokinetics in more detail. Clearance, half-lives, distribution volume, absorption, and bioavailability. First, the term bioavailability. Fraction of a drug that reaches the systemic circulation, or percent of a drug that reaches the systemic circulation. It's shown with capital F, which means fraction. And if we consider oral nystatin, which is antifungal drug, or oral gentamicin, an antibiotic, these drugs have no absorption when they are administered orally. So, capital F, or bioavailability for oral nystatin or gentamicin, is almost zero, since we have no absorption. For some drugs, like testosterone, we have complete absorption after oral administration, but the metabolism is very high. Almost all drug that reaches the liver is metabolized. So again, bioavailability is almost zero for testosterone. Here we have a formula. Bioavailability equals a small f multiply and here we have 1 minus ER, or extraction ratio. A small f is the amount of drug that is absorbed, or the fraction that is absorbed. For morphine, oral morphine, if we consider the small f 1, it means that we have complete or total absorption, 100% absorption. ER refers to amount of metabolism. So, extraction ratio in this case is 0.67 here. And then, if we put this number in this formula, we have 0.33. This is bioavailability. So, in oral route, a part of drug may not absorb, and a part of drug after absorption may metabolize. So both absorption and metabolism can affect the bioavailability. Another term, first pass effect. After oral administration, we have absorption, and the drug after absorption reaches portal vein and reaches the liver. If we say that a drug has high first pass effect, it means that it has a high rate of metabolism in liver. For testosterone, as an example, we say that it has a high first pass effect. It means that by first passing through liver, most of drug is metabolized. A comparison of bioavailability through different routes. IV, intravenous. By definition, in IV route, we have 100% bioavailability. As I said, bioavailability is the fraction reaches the systemic circulation. So in IV route, we push all the drug, or we deliver the drug to systemic circulation. So in IV route, we have 100% bioavailability. In intramuscular or subcutaneous, you see the bioavailability from 75 to 100. In oral route, you see that bioavailability may varies from 5 to less than 100% due to absorption and metabolism. In rectal route, when we use suppositories, as I said in previous session, we have a bioavailability of 30 to less than 100. Inhalation, like oral. And here we have transdermal, through skin. Bioavailability may differ from 80 to less or equal 100%. In pharmacokinetics, we have another term, volume of distribution, or VD. And this is the formula. VD equals amount of drug in body divided by blood concentration. CB, blood concentration. If we consider sugar or salt, and if we dissolve sugar or salt in a specified amount of liquid, water, we have equal distribution. If we take sample from each part, the concentration is the same. When we have equal distribution. In the body, it is completely different. Some part of the body is bone. The drug may not reach the bone. A part of the body is fat tissue. Lipophil drugs have tendency to accumulate in fat tissue. In some parts of the body, we have barriers. For example, blood-brain barrier, BBB, blood-brain barrier. So they don't reach to CNS. In the body, we have not equal distribution. And we have VD, which is volume of distribution. Sometimes for a drug, volume of distribution may be 2,000 liters. If we consider that an adult person is about 70 kilograms, and if we consider that the density is 1, so the total volume of the body for an adult is 70 liters. But according to this formula, for some drugs we may have 2,000 liters or 20,000 liters. It means that if we distribute the drug uniformly or equally in such a volume, we have blood concentration. The concentration will be equal to blood concentration. If drugs have tendency for tissues rather than blood, then volume of distribution will be higher. And if the drug remains in the blood, suppose that you prescribe a drug and most of the drug remains in the blood. As the drug remains in the blood, the volume of distribution will be less. Okay? For drugs with good tissue distribution, we have a higher volume of distribution. Volume of distribution is used for determining the dose of drug, and later I'll talk about it in more details. Here we have half-life. Half-life. And this is a simple formula for half-life. 0.693 times VD, volume of distribution, divided by clearance. If a drug has a higher clearance, then half-life is less. If we have a high volume of distribution, then half-life will be good or great. So this is the half-life. We have two forms of half-life. One of them is elimination half-life. And it means that the time that the concentration in the blood reaches 50% of the initial concentration. Suppose that at this time the concentration is 20. After 8 hours we have 10. 50%. Okay? The time is half-life. We say that the half-life is, for example, 8 hours, 6 hours. This is elimination half-life. We have also biological half-life. And it means that the time that the effect of drug reaches the 50% of the initial effect. We have elimination, which relates to concentration, and biological half-life, which relates to effect. Is used to inhibit platelet aggregation, is used to prevent MI, myocardial infarction. Aspirin has an elimination half-life of 1 to 1.5 hours. For aspirin, the elimination half-life is 1 to 1.5 hours. But biological half-life is completely different. Any platelet that receives aspirin is non-functional. The lifespan for platelets is about 8 days. Any platelet in the body, in the blood, has a lifespan of about 8 days. And any platelet that receives aspirin is non-functional for its lifespan, since aspirin covalently binds with cyclooxygenase, an enzyme in the platelet that is important in aggregation. In other words, aspirin irreversibly can inhibit cyclooxygenase in the platelets. So here, biological half-life is much longer than elimination half-life. You see a diagram. When we start a drug for the first time, we prescribe the drug and we start the use of drug. Little by little, the concentration will increase. Here we have half-lives, 1, 2, 3, 4, and more. After 5 half-lives, we reach about 97% of maximum possible concentration in the blood. So, if a drug has a half-life of 8 hours, after 40 hours, we reach that point. And we say a steady state concentration. After 5 half-lives, we reach a steady state concentration. In other words, we have little by little accumulation of the drug. When we stop a drug after long-term use, suppose that the patient has used the drug for 6 months, and now you stop the drug. You see that after the first half-life, we reach 50% of the initial concentration. The initial is 100. And then after the first half-life, we have 50%. After 2 half-lives, we have 25. The remaining drug is 25%. After 3, we have 12.5. Okay? And after 5, only 3% of drug has remained in the blood. So, when we stop a drug after long-term use, it takes 5 half-lives to say that almost all drug has eliminated. This is when we start the drug, and this is for stopping. Suppose that a patient has referred to you with hypertension. Okay? You prescribe a drug. We say that the best effect may reach after 1 or 2 weeks. It means that after 1 day, after 2 days, we have the effect. We see that blood pressure is coming down, lowering. But the best effect is after 1 or 2 weeks. So if we want to double the drug dose, if we want to increase the dose, we should wait for 1 to 2 weeks. Since we have little by little the accumulation of the drug, and the best effect will be after 5 half-lives, depending on the half-life of the drug. If a drug has a half-life of 24 hours, 1 day, after 5 days, we reach 97% of the maximum possible concentration in the blood. What's the significance of half-life? Half-life determines duration of action, time interval for using drug. You see that for some cases we say 4 times a day, 3 times a day, every 8 hours, every 12 hours. These are depending on half-life. And if a drug has a longer half-life, it's a benefit. Suppose that a patient has hypertension and you have 2 drugs, one with a half-life of 6 hours and the other with a half-life of 24 hours. 24 hours is better since we can use it once daily and it's more convenient for the patient. It's okay? It's very convenient.
So why we cannot use the drug which has half-life of 6 hours?
All of them. But we say that the compliance is when the patient obeys your guidelines or your orders. We can use all of them. But once daily for a patient who wants to use the drug for lifelong is much better. Instead of using 4 times a day, we have once daily. Sometimes for children, you should awake the children to take the drug. But if we have a drug with a higher or a longer half-life, then it's much easier. Let's compare 2 drugs. Do you know erythromycin?
Yes.
Erythromycin. Erythromycin is an antibiotic from macrolide family. We have also azithromycin. One of the differences between these 2 drugs is their half-lives. Azithromycin is once daily, while erythromycin should be administered 3 or 4 times a day. And nowadays, most physicians prefer to prescribe azithromycin. How we determine the dosing of a drug? Sometimes we have a fixed dose. For example, mebendazole is an antihelmintic drug for warts. Okay? And it can be used over 2 years old for every patient who is greater than 2 years old. Okay? The dose is not different for a child who is 4 years old and grandfather who is 94 years old. We say that we have a fixed dose. For sore throat, pharyngitis, when we have streptococcal pharyngitis, we say that if the weight of the patient is over 27 kilograms, then we use 1,200,000 benzathine penicillin G. And if the weight is less than 27, half of this dose is used. So based on the weight, we have fixed dose. For a patient with 60 kilograms is the same as 30 kilograms. More than 27 is the criteria. So sometimes we use drugs as needed. For example, acetaminophen for headache. We say if necessary or as needed. An asthmatic patient may use salbutamol spray to dilate bronchi as needed. Or a patient who has ischemic heart disease, in cases of ischemic attack, may use a sublingual nitroglycerin to control the heart pain. Okay? These are as needed. Sometimes we have loading dose or maintenance dose. Loading dose is VD, or volume of distribution, times target concentration, TC. As as I said previously, we need 5 half-lives to reach the best effect. Sometimes in emergency situations, in emergency cases, we want to shorten the time and we want to reach the best effect sooner. Here we use loading dose. Loading dose is a higher dose that reaches the best effect sooner. And it's most often is used in emergency situations, in hospitals, in clinics, not for outpatients. Maintenance dose is the dose that maintain or keep the target concentration, and its clearance times target concentration. Maintenance dose depends on clearance. It means that as the drug is eliminated from the body, we should add drug to the body. Okay? We have maintenance dose for outpatients that the patient has referred to your office. Okay? And we have loading dose for hospitals and for emergency cases. 3 different ways for administration of a drug. In this case, we have added the drug to Baxter, to a high amount of fluid. You see in hospitals that we have Baxters, dextrose Baxter, NaCl, sodium chloride, or mixture of them, Ringer, different infusion fluids. You can add the drug to these Baxter, and drop by drop you can enter the body. Okay? Here you see that half-life for this drug is 8 hours. And after 40 hours, after 5 half-lives, okay, we reach a concentration about 97%. And then, if we continue the infusion, we have a constant concentration. We have no fluctuation. Here, we have used drug by IV or bolus IV. We have injected IV. Here, we have the initial concentration. After one half-life or after 8 hours, we have this concentration. Again, we inject the drug. So we have a new maximum. And then, little by little, we have clearance of the drug and we have a trough. We say maximum here and trough, minimum concentration. And we continue administration of drug at 8-hour intervals. Okay? What happens after 5 half-lives? We have a steady state. Maximums are very close to each other. And minimums are also close to each other. Here we have differences between maximums. You may say that instead of administering at 8-hour intervals, I use threefold drug at 24. We have the blue lines. You want to use here 1 gram each 8 hours. Instead of 8 hours, you say that I use 3 gram for 24 hours. What happens? Fluctuations are very wide and it may be very dangerous. At some times we may reach toxic concentration. So you are not allowed to combine the drug and use a longer interval. You should use this pattern. You may say that in this case, the patient is convenient. But sometimes we have very high concentrations and it may reach toxic concentrations. For drugs, we have a therapeutic window. Okay? Here, suppose that therapeutic window is between 5 and 15. Therapeutic window. It means that if we have the fluctuation of the drug between this range, then we have the effect. If the concentration is in this part, here, less than 5, we say that it's subtherapeutic concentration. And we have not reached the therapeutic level. And if the concentration is greater than 15, we say it's toxic concentration. Therapeutic window is between subtherapeutic and toxic. So in this case, at some times we have toxic concentration. When we have blue lines, you see that. In sometimes the concentration is more than 15. And this is toxic. So here we have a comparison between infusion. Only in infusion we have a constant concentration. In other routes, oral, IM, IV, we have fluctuations. And the range of fluctuations depends on intervals of administration. We have renal clearance, liver or hepatic clearance, clearance from other routes, and the sum of all of them is systemic clearance. For some drugs, for example, gentamicin, we say that clearance for gentamicin is about 98 to 99 from kidneys. So we have renal clearance. And the importance is that in cases of kidney insufficiency or renal insufficiency, we should adjust the dose. For drugs that have a high renal clearance, in cases of renal insufficiency, we should adjust the dose. If we don't do, we have toxicity. The dose is for normal kidneys, kidneys with normal function. So in renal insufficiency, we should adjust the dose for those drugs that have a high renal clearance. And in liver insufficiency or hepatic insufficiency, we should adjust the dose for those drugs that have a high liver clearance. Let's talk about metabolism. The most important site for metabolism is liver. It has different cytochromes, different enzymes that can modify the molecule. Metabolism is enzymatic. Enzymes are involved in metabolism. We have two phases in metabolism, phase 1 and phase 2. Phase 1 is oxidative process, and phase 2 is conjugation. In phase 1, polar groups like
hydroxyl, carboxyl,
carboxylic, amine, sulfitryl, these groups are produced or added on their molecule. In phase 2, we have conjugation. Conjugation with glucuronide, sulfate, glycine, glutathione. So we have two phases. If a drug has polar groups by itself, for example, morphine has two OH groups, so it can directly conjugate it. Okay? So if a drug has polar groups, it does not need to enter phase 1 process. It directly conjugates with glucuronide or other. The objective or aim of metabolism is changing lipophilic drug to hydrophilic drug to be freely eliminated through kidneys. The aim of metabolism is detoxification. Any drug that enters the body, the liver manage it as a foreign matter and wants to modify it to be excreted through kidneys. Sometimes drug is directly eliminated. We say that we can see intact drug without any modification. We can see intact drug in urine. Drug may enter phase 1 or phase 2, and then the metabolite is excreted. Sometimes drug metabolite has activity, and some metabolites are inactive. Suppose that a person has used heroin. Heroin in the body can be converted to morphine. So we say that morphine is an active metabolite of heroin. Okay?
Yes.
Metabolites may be active, may have biological activity, may be toxic, In some cases, metabolites are toxic. And if we have no toxicity, no biological activity, we say inactive. So for all drugs, we have active, toxic, or inactive. Diazepam is a sedative hypnotic drug. It induces sleep. A part of diazepam molecules can be converted to oxazepam. Oxazepam has also biological activity. And we say that one of active metabolites of diazepam is oxazepam. Imipramine is an example of antidepressant drug. In metabolism process, a methyl group, CH3, is detached from imipramine. And we have desipramine. Desipramine has also antidepressant activity. So we say that this is an active metabolite of imipramine. In the blood, you may have several metabolites for a drug. Some may be active, some toxic, some inactive. And in some cases, all the metabolites may be inactive. It depends on the drug. This is an opioid, an analgesic drug from morphine family. This drug is converted to norepinephrine by liver. And if we have a high concentration of this metabolite, then we have convulsion. So we say that this is a toxic. It causes convulsion. It causes seizure. Okay? In cases of renal insufficiency, this metabolite may accumulate in their blood and cause toxicity. Some drugs are completely safe in therapeutic doses. We say that for adults, acetaminophen, if used under 3 grams per day, it's completely safe. But high doses is hepatotoxic. So for some drugs, when we use therapeutic doses, we have no toxicity. But higher doses will cause toxic effect. If you are tired, we can have a... Here you see a drug that is used for tuberculosis, isoniazid. And we have the metabolic pathway for this drug. Sometimes phase 2 is carried out first. And then we have phase 1. Here we have this example. First you see that acetylation occurs on isoniazid molecules. And then we have hydrolysis. Phase 2 first, and then phase 1. In phase 1, we have polar groups. Suppose that the drug is RH at right part. We have RH, okay, here. And RH should be converted to ROH. Here we have cytochromes. You know that we have cytochrome P450 for metabolism. And cytochrome P450 may be in oxidized form with Fe +3 or in reduced form with Fe plus 2. This is ferric and this is ferrous. Yes. Drug binds with cytochrome when it's in ferric form. And then we have cytochrome P450 reductase, an enzyme that reduces Fe plus 3 to Fe plus 2. When we have this situation, or ferrous form, oxygen comes in the field. And one atoms of oxygen will change RH to ROH. And the other one makes water. Here you see how cytochromes act. How a drug, which is RH, is converted to ROH. And how a polar group like OH is produced on a molecule. We have the cycle and the activity of cytochromes. We have metabolism of acetaminophen. I said that when we use therapeutic doses of acetaminophen, we have no toxicity. In therapeutic doses, acetaminophen, a part is glucuronide, which is non-toxic. A portion of molecules of acetaminophen are sulfated. So we have non-toxic sulfate metabolite. And then we have, after filling up of the capacity for glucuronide and sulfate, we have cytochromes in the middle. When metabolism occurs with cytochrome, we have quinone metabolite, which is hepatotoxic. If the amount of this toxic metabolite is low, then we have conjugation with glutathione. Okay? Yes. But the amount of glutathione is in liver limited. So we have accumulation of this toxic molecule and injury to liver cells. So we have hepatotoxicity. When we have therapeutic doses, only we have glucuronide and sulfate metabolites, which they are non-toxic. But in cases of high doses of acetaminophen, for example, in suicides, okay, in these cases, we have a high amount of acetaminophen, and then we have accumulation of quinone metabolite, which is hepatotoxic. For acetaminophen toxicity and controlling or treatment of acetaminophen toxicity, we have a drug called NAC, which is N-acetylcysteine. N-acetylcysteine can bind with this toxic metabolite and detoxify the metabolite. We have NAC for acetaminophen toxicity. In this slide, you see the involvement of different cytochromes in metabolism. Above 36% of drugs are metabolized by cytochrome 3A4. All of these are different isoforms of cytochrome P450. Different isoenzymes or isoforms of cytochrome P450. And This one has an important role in metabolism of many drugs. Some drugs can induce cytochrome P450. Cytochrome P450 is a protein, and its amount is under the control of genes. So, drugs may induce cytochrome P450. Here we have some examples. Phenobarbital, phenytoin, carbamazepine, rifampin are inducers. It means that they increase the amount of cytochrome P450. So they increase the rate of metabolism of other drugs. And here we have drug interaction. We say that if a person is using phenobarbital, for example, in this patient, the rate of metabolism of warfarin is much higher than the patient who does not use phenobarbital. We have also inhibitors of cytochromes. These are some examples. Erythromycin, ketoconazole, cimetidine. They inhibit cytochromes. So they inhibit metabolism of other drugs. And they increase blood concentration of these drugs. So we have inducers and inhibitors for cytochromes. Is inducer in cigarette smokers, the rate of metabolism of many drugs is much higher than non-smokers. So the rate of metabolism is dependent on many factors. And the amount of cytochromes is an important determinant. Sometimes we have inhibitors of metabolism in some fruits. Here we have grapefruit juice. In grapefruit juice, we have an inhibitor of cytochromes. And if a person drinks a lot of grapefruit juice, then it can inhibit the metabolism of many drugs. Here you see a drug which is felodipine. Here we have the diagram without using grapefruit juice. And this one is with juice. You see that blood concentration or plasma concentration in this case is much higher. I said that in grapefruit juice we have an inhibitor of cytochrome P450. And grapefruit juice can interact with more than 200 drugs, especially when high amounts are drinking. Okay? If a person uses only a half of a glass, no important, no problem. But when we have high amount of fruit juice, then we have interactions, and it's very important. Suppose that a patient is using warfarin, and then 2-3 glasses of this juice. We have a higher concentration of warfarin. What happens? Bleeding will occur because of high concentration of an anticoagulant. It causes bleeding.